Mr. Gyan, especially for this invite. It's wonderful to be here with a galaxy of glaucoma experts. And in the next few minutes, I would take you through TAFLUPROST, my experience in the Indian eyes. So we've heard from my previous speakers that current challenges in glaucoma management, very well put forward by Dr. Shibal, is a challenge, and barriers to health care uptake, like glaucoma is often remains undiagnosed. It's difficult to detect in early stages, IOP being normal, and there's a high dropout rate, and there is a lack of the disease awareness in the population. The efficacy aspects of IOP measurements. IOP is a highly individual and dynamic method. IOP changes from baseline, the mean IOP change. Baseline IOP is always what we are looking at, but sometimes we cannot do it because the patient doesn't have records and we haven't seen the patient first, already on anti-glaucoma drugs. 24-hour IOP fluctuation monitoring, that's a challenge, which Dr. Samira also spoke about, and the responder rate to treatment, well, that needs to be seen, and persistent long-term IOP reduction is always a challenge. So what to check in a busy practice, what is idle and what is practical, let us see. So the efficacy of one-time IOP recording is often misleading, can be a poor indicator for diagnosis and treatment, and poor surrogate of the entire IOP profile of a patient with glaucoma. So a drug with proven 24-hour IOP control is actually what we are looking for. And the adverse effects, commonest, they have already been spoken about, so I don't need to go through them in detail. I just would like to share this analysis of 36 randomized controlled trials that included 17,511 patients, which identified that adverse effects as the most common cause of withdrawals. That's 46% of withdrawals compared to 10% of withdrawals for inadequate intraocular pressure control. So survey results confirm that the impact of adverse effects on adherence in real life as well as in clinical trials. So the high dropout rate in glaucoma treatment actually is seen with almost all glaucoma medications, as you see from that graph out there. All of them actually have a dropout rate, and as very well stressed by my previous speakers, it's like quoting Dr. Shibal once again, is that glaucoma doesn't produce symptoms until you actually start treatment. How true that sentence is actually. So from there, we move on to the menace of hyperemia. Dr. Sethan did a wonderful job of getting across to us that hyperemia, how annoying it can be. And 27.4% of patients with hyperemia were discontinued from their medication. So patient adherence, continuation of treatment, and IOP control all seem to pose a challenge. Why so many dropouts? Factors on the treatment provider side. We have installation failures. We can have adverse events profiles or without a good IOP control, difficulty with medication schedule, difficulty with drop administration, and of course, in our country, cost is always a huge factor. But we also have factors on the patient's side, like low awareness of glaucoma. They think, what for am I using these drops? I don't have anything. And then, of course, they forgetfulness. So the criteria of a novel PGA, properties of the ideal anti-glaucoma molecule that we look for, the unique drug design of TAFLUPROST, the landmark studies on saflotin, clinical efficacy of TAFLUPROST, and safety and tolerability is very important. So we did find it does have an effective IOP control, quick IOP lowering effect, better circadian control over the IOP fluctuations, higher responder rate, and consistent long-term IOP lowering effect. Tolerable and safety profile, it has a low overall incidence of adverse drug reaction, preservative-free or optimized preservative content. But now we do have the preservative-free version of it, and associated with stable visual fields, improves orbital microcirculation. I'm still to actually see that. But the top story here this evening is actually the unique drug design of TAFLUPROST, which is the fluorine atoms bestow a more potent affinity for the prostanoid FP receptor than that exhibited by the other PG derivatives. So if you look there, it's like the 15th position of that is actually substituted by the difluorine atoms out here, which is different from all the other prostaglandin analogs. And if you look at that, what it actually does is that the electron attraction, high receptor interaction, high FP affinity, strong IOP lowering effect, strong and durable stability, storage at room temperature, and lipophilicity, improved PK, and prolonged and improved ocular blood flow. So with that, we move on to the study which was done where they actually found that the difluoroatoms increased tafluprost binding capabilities over the other PGAs, as you see out there. And this is actually a unique feature to tafluprost, where it actually activates signaling and this collagen matrix by releasing the metalloproteinase. It causes this cleaved matrix, and which actually causes outflow in the trabecular meshwork as well, secondary to the uveoscleral outflow. So the inference of the story is that my experience, well, we have been using the drug for from the time it was launched in India, that's somewhere I think in November, and then Case 1 is initiation of tafluprost in treatment-naive patients. So this was a 55-year-old female patient, a housewife, had not had a complete eye examination for several years. She was diagnosed with primary open-angle glaucoma in both eyes, and the baseline IOP, right eye was 26 and left eye was 24 millimeters of mercury. She had early cataract in the left eye and systemic hypertension for 7 years. I told you that she's a treatment-naive patient, and we decided to start PGA. So decision made to start the treatment with saflotin preserved with buck. That's when we did not have the preservative-free version. There was significant IOP reduction observed in both eyes at week 4 and 12, no incidence of observed side effects. And she started with 26 and 24, and then ultimately at the end of 12 weeks, it was 19 and 18. This is case 2, switch from latanoprost to tafluprost. So this was a 58-year-old male patient, a teacher in a government school, diagnosed with, again, primary open-angle glaucoma in both eyes since 5 years, no family history of glaucoma, early cataractus changes, systemic hypertension for 6 years. The patient was diagnosed with primary open-angle glaucoma 5 years back and prescribed latanoprost. So decided to switch to tafluprost due to non-availability of the current therapy. Latanoprost was not available for quite some time. So the decision was made to switch, and by then we had the saflotin, and IOP was further decreased at week 4 and week 12. At week 4, there was mild conjunctival injection and observed in the right eye. At week 12, it was clear, and the IOP was 16 at 12 weeks in both the eyes. This is case 3, switch from tavaprost to tafluprost. So 55-year-old male patient, avid reader, diagnosis of primary open-angle glaucoma in both eyes since 3 years. Nothing significant in the systemic conditions. Initial treatment, patient was on treatment with travoprost since last 3 years and was also using Cysteine Ultra, that's the tear substitute with polyquad as the preservative. And we decided to switch to tafluprost preserved with buck. And the decision was made to switch to saflotin. So the patient got further IOP reduction at week 4 and week 12. If you look at that, it came down to 20 and 18. And there was no incident of observed side effects. And mind you, we had stopped the Cysteine Ultra. This is case 4, switch from tafluprost to preservative-free tafluprost. So this was a 55-year-old working female patient who was again diagnosed with primary open-angle glaucoma, had dry eye and mild ocular hyperemia. Patient was on treatment with tafluprost with buck since last 1 month. So once we had the buck-free tafluprost, we switched her over to that. And the preservative-free tafluprost maintained IOP at the same level. And if you look at that, the conjunctival redness, the ocular hyperemia score, it did come down drastically, and IOP also was maintained. So with that, I move on to case 5, that is 42-year-old female, a patient, a software executive from Nagaland, northeastern India, has not had a complete eye examination for several years. So a gonioscopy showed that she had Sheffer's grade 1 and 2 over 280 degrees in both eyes. Diagnosis of primary angle closure suspect in both eyes with baseline IOPs of 26 and 28 millimeters of mercury. She complained of frequent headaches at the end of the day, and her mother did have primary angle closure glaucoma. So prophylactic YAG-PI was done in both the eyes, and she was kept a week on dexamethasone and dorzolamide drops. Gonioscopy repeated after a week, and with the patent PIs, the decision was made to switch to saflotin. and significant IOP reduction was observed in both the eyes at week 4 and week 12, and there was no incidence of any observed side effects. So with that, we actually inferred that the IOP was significantly reduced by 4.2 plus minus 4 millimeters of mercury in the new monotherapy group, 1.9 plus minus 3.6 millimeter of mercury in switching from prior treatment, and 3.8 plus minus 4.6 millimeters of mercury in the add-on therapy group. IOP was significantly reduced in patients who switched from latanoprost, travoprost, and other glaucoma medications. And the overall reduction was about 3.8 plus minus 4.4 millimeters of mercury. There you see in patients who were first started on TAFLUPROST with a 24 millimeter mean IOP. The IOP did come down at 4 to 6 weeks to 16, and then it maintained at 12. That's almost 32% reduction in IOP. So more than 30% IOP lowering in treatment with new patients at 12 weeks. And that actually is TAFLUPROST versus latanoprost at 6 weeks, achievement of IOP reduction. So here as well, if you look at that, we actually saw 80.8% of cases achieve 20% or more IOP reduction by TAFLUPROST as compared to latanoprost, which achieved 71.6%. The safety profile, saflotin administration resulted in 39 eyes which had adverse reaction in 21 patients out of the 295 patients who we could actually follow up, considering all the lockdown and everything that we had. And the percentage of patients with adverse drug reaction was about 7.1%. The most frequent adverse drug reactions were hyperemia. We did that calculation on the clinical grading of hyperemia, and blepharal pigmentation and OSD. We generally saw the Shermas and the TBUT timing, and that's how we came to that. That's 2.8% actually. And so the laurels that I would attribute to the molecule are excellent receptor affinity and selectivity, proven IOP lowering efficacy comparable to other prostaglandin analogs, additional IOP reduction in glaucoma patients who have been on other medications, and superior safety and tolerability. We do have the bark-free variety now. And that is it. Thank you for your attention.
Thank you, Dr. Chandrima, for